Hi, in this short video, we'll talk about Brown-Sequard syndrome and how to identify it on clinical vignettes. So in Brown-Sequard syndrome, you have a lesion to one half of the spinal cord. We call that a hemisection. It is diagnosed by MRI, and it shows a specific pattern of sensory and motor loss. And it's mostly a result of a traumatic injury. Here you can see a lesion here in the cervical region. Here again, this particular lesion does not conclude a whole hemisection and anything on the other side. However, in all the examples we're going forward, we consider a whole hemisection affecting only one side totally of the spinal cord in one section. What you need to remember is that patients with Brown-Sequard syndrome suffer from ipsilateral loss of touch, vibration, and proprioception, ipsilateral motor paralysis, and contralateral loss of pain and temperature sensation. If you ever see this disjointment of ipsilateral touch, ipsilateral motor, and contralateral loss of pain, you know it happens at the spinal cord and it is Brown-Sequard syndrome. That should be it, but now we'll talk about why that is so you understand the reasoning behind this. Right? Remember, at the level of the spinal cord, touch axons enter the spinal cord and immediately ascend on the ipsilateral side all the way to the medulla. However, pain axons enter, they synapse, decussate to the other side and ascend on the contralateral side. That's very important to understanding the dissociation between the touch and the pain deficits you see in Brown-Sequard syndrome. Okay, at the level of the lesion, here at T5 on the left spinal cord, you have touch cannot enter because all the tissue is destroyed there, right? Pain cannot enter. So you have a deficit there at the lesion because pain cannot bring its information up to the spinal cord and into the cerebral cortex. Now, below the lesion, you also have a loss of touch because even though the information here can enter at the spinal cord, it cannot go through the damaged kind of part of the spinal cord here at the level. So you also lose ipsilateral touch below the lesion, right? And you lose contralateral pain below the lesion because here pain enters and tries to ascend on the contralateral side. Now with Lissauer's tract, two levels below the lesion, you have pain cannot cross and enter and reach the cerebral cortex at no place. However, one level below the lesion, it looks very different. At one level below the lesion, you actually have some parts that can make it to the cerebral cortex, and then you perceive pain. However, because the number of the fibers here isn't so much, your pain perception is either reduced or it only is restricted spatially on the dermatome. Okay, to summarize, at the level of the lesion, you have ipsilateral loss of touch and pain. In contralateral, everything is fine. Below the lesion, you have ipsilateral touch, vibration, proprioception not happening, right? So you have a deficit there, and pain and temperature is fine. Contralaterally, touch is fine, but pain and temperature is impaired, right? So again, to summarize, if you see a patient who has ipsilateral loss of touch, vibration, and proprioception, ipsilateral motor paralysis, and contralateral loss of pain and temperature, it is a Brown-Sequard syndrome. Thank you for your attention.